My name is Dr. Patrick Soon-Shiong. I am Executive Chairman and CEO of a company called NantWorks, whose mission is to find solutions for patients suffering from life-threatening diseases such as cancer and infectious disease. I'm also the Executive Chairman of Los Angeles Times, and I'm here today to present more information in an updated series on understanding the science behind the coronavirus. Very recently, my executive editor, Norm Pearlstein, shared with me a comment that unless we understood the dynamics of this virus, we could provoke an existential crisis. With that comment, I realized there's a huge amount of fear and consternation, and rightly so, but I wanted to present this episode today so that we can understand that we need not panic. The fear that is out there has been accentuated by three factors, I believe. Number one, the unknown, meaning who's infected, who's not infected. The unpredictability as a consequence of that. Number two, how long will this nightmare pandemic last? And number three, the thought or the feeling that this virus is uncontrollable. I'm here to assure our readers and those listening that the scientists of the world are hard at work 24/7, and I'm more confident than ever that we have now enough science and knowledge about this virus to beat this thing. Unfortunately, because the way the virus has occurred through this ACE receptor, the infectivity of this virus is enormous. And as I presented in our last episode, this virus has found a way to activate and hijack our body by taking on this ACE2 receptor, which is in our lungs, nose, and in other areas of our body, and therefore become highly infective. Yet, because it's done that, it is an Achilles heel, and we have an opportunity to stop it and attack it. In addition, this ACE receptor doorway, so to speak, was the same in SARS 2003, which means we as scientists have had a jump start in understanding how to attack this virus. So today, my goal is to present to you some more elements about this COVID-19. And unfortunately, it is my belief, in my opinion, that this virus is here to stay. It doesn't mean, however, it's here to stay and we can't defeat it. It's here to stay as a human-to-human transmission, and it's here to stay because it will mutate. But we will have, and I will share with you, our strategies in which we can overcome this virus, ultimately, and convert what we consider now a fatal disease, a frightening disease, to a virus that we'll be able to manage like that of the flu. Especially as we're learning day by day, in most rapid fashion, what's going on with this virus, what's going on clinically, how we can understand it, and how we can move on. I also want to share with you that is my belief now that we can categorize this virus into three conditions. Firstly, the asymptomatic patient. It is one of the differences with regard to this virus infectivity that a patient could be infected and yet asymptomatic. I believe, however, that this is also one of the reasons why it is so infective. We don't know who's infected, and the asymptomatic patient inadvertently could be transmitting these infections through travel, through their droplets that actually contaminate surfaces, and inadvertently creating the spread of infection. And we'll speak to this asymptomatic patient, which happens to be, I believe, over 50 to 60% of the patient population ultimately, and what they can do to help us control this pandemic. But then there are patients who are infected with mild to moderate symptoms, who I call the symptomatic patient, and that's going from yellow to orange. And this symptomatic patient will have an opportunity today, with the rapid onslaught of the clinical trials, as well as our knowledge from SARS 2003, of what drugs that could be repurposed for the purpose of mitigating this disease and not allowing these mild to moderate patients to become critically ill. Which then takes us to the critically ill patient, which is what I call the red. And unfortunately, these critically ill patients have such severe lung injury and damage because of this virus and the desire of the body to fight it. Because the immune system is fighting so hard, it creates tissue injury in its own right and fibrosis and requires oxygenation and ventilation. Sadly, the results today are for these critically ill patients, almost 50% of them succumb on these ventilators, and they succumb rapidly. And in New York, that number is even higher. According to physicians working there and sharing some of this information with me, the fatality rate among those on ventilators is as high as 80%. So if you look at this yellow, orange, and red, we are now very rapidly understanding clinically what's going on with these patients, and we are developing strategies for each of these groups. My job today is to describe these three groups and the strategies of how to go about addressing the asymptomatic patient, the symptomatic patient, and the critically ill patient. However, at the end of the day, in order for an inflection point to occur, where this pandemic will end, and if the next pandemic occurs, we'll have ways and prepared to fight it, where there is a light at the end of the tunnel, is this race for the vaccine. And you've heard multiple reports of varying time frames of when a vaccine will occur, whether it'll be 12 months, 18 months, 24 months. I want to present to you some data today that there's some hope that it'll be even sooner than that. But I need to also put into perspective of what a vaccine is. How does it work? What's the difference between short-term immunity, long-term immunity? What's the difference between what we call humoral immunity and cell-mediated immunity? And in fact, what's exciting is how does this vaccine, so to speak, not differ very much from the attempts that we're trying to do with immunotherapy in cancer today to generate what we call a memory vaccine. So I believe that this race for a vaccine is, while exciting for scientists, will be the basis for the end of the nightmare. So my proposal today is to spend time going through these elements of explaining about the pandemic, presenting elements of strategies which are very real and learned since 2003 that we can address and beat this virus, describing for you the differences of this asymptomatic patient, the symptomatic patient, when the patient has to go to hospital, the severely ill patient, what opportunities there are to save that life and reduce the fatalities, and finally the light at the end of the tunnel that in fact a vaccine is at hand. Let me turn first to why I believe COVID is here to stay. Not to alarm you, but to present to you the science of how this virus has evolved, and more importantly, how it is now a human-to-human transmission, and we have to deal with it. But more importantly, we now have to understand it, and we can deal with it. This all started in 2003. This virus, we believe, emitted from the bat. Bats have such an amazing number of species across the planet. So it transmitted between bats and multiple viruses within the bats. And the bat virus then found an intermediate host in a form of what they call crivets or cats. And that resulted in China in 2003 of one of the first transmissions from an intermediate host of a mammal to a human. Fortunately, SARS 2003 stayed contained in the sense that the SARS was not that infective and was able to be contained, and as you could see, 774 deaths. There's a silver lining in that, because this SARS-CoV in 2003 is the parent of SARS-CoV-2 because mutations occurred, which means the scientists have had a head start of about 16 years to understand how this virus attacked the human body and how it hijacked the human body. In the interim, in 2012, it transmitted from a bat to a camel, and in Saudi Arabia to the Middle East, and that's called MERS, which is a variant of this. Between SARS and MERS, it hit 30 countries and 27 countries and had limited exposure. And that's what we meant by an epidemic and not a pandemic. All of a sudden in 2019, it went to human, and then from human to human. And that is when this became really dangerous, because now there's, for the first time, a real human-to-human of a virus that's never been seen in us as a host. And by 2019, in China, there were 5,000 deaths. So that was the first evolution of this virus from human to human. And because none of us had ever seen this virus and the ability of this virus to not only become so highly infective, but so toxic, the fear is in the United States, we may even possibly hit a high of 100,000 to maybe even 200,000 deaths. And that is why I think there's this great fear about this pandemic. But I think there's an opportunity for us to understand this pandemic as we work through the science. And what we've seen through the science is the ability of this virus to mutate. And this is an amazing graph of all the genomic sequences since the initiation in China of the first virus, as you could see in purple, are the beginnings of these mutations. And what mutates mainly is the surface of the virus, the spike. And as you could see, as it mutates and goes around the countries, there's ongoing mutations. And I believe the amazing thing about this virus, it has to mutate in a funny way in order to survive, because if it's as aggressive as it was in China, it would create its own extinction by not having a host survive. So it mutates, and as you could see, the red is the mutation in the United States. And what do we mean or understand by this mutation is the good news. There's a significant number of base pairs or parts of the genome that are conserved. The thing called the receptor binding domain, the domain of the virus that binds to the ACE receptor, the domain inside the structural protein of the virus called the nucleic capsid are conserved. Why is that important? Well, the reason that's important is that we now have ways to attack these conserved portions so we can actually end this pandemic. And this is what the pandemic looks like. This is what we call the evolution of a pandemic, starting in China for the first human-to-human transmission of a virus that's never been in the human population. Therefore, none of us had immunity. And the rapid spread around the world and all the way now in the United States. I think this map clearly shows the evolution of this spread. It's a remarkable testimony that we are one community, one global community. And as it spreads from China to Europe, to the United States, to every part of this world, we have the pandemic, and this is why I believe this virus is here to stay. From the world to the United States. Unfortunately, one of the epicenters is New York, and whether New York has hit its peak yet is hard to know. And credit to the governor of California, we have significantly lower numbers. Perhaps we haven't touched the peak yet, but I think one of the lessons that we learned in California was the very early announcement of Governor Newsom to create the stay-at-home policy, to limit the beaches, to limit exposures of crowds. The NBA that canceled all games. It is our hope that this limitation of contact will mitigate this spread. Clearly, one of the fears we have is not only is this virus highly infective, it is highly toxic. And the toxicity we haven't yet worked out because we don't have enough data, what percentage of patients who are getting infected are toxic. There were estimates that it was 20 times that of influenza. But what we do know is that if a patient enters into what we call the critical phase, the ICU phase, sadly, the survival rate or the death rate or fatality rate is 50%, which is an enormous number. If you look from California to our local areas in Los Angeles, you begin to see in the highly dense populated areas, both of LA, and LA is now a hot spot relative to California. And within LA, the areas of Brentwood, Santa Monica, and Long Beach. It is our hope, however, that the work that both the mayor and the governor has done to mitigate the spread by creating this stay-at-home policy will keep these numbers down. So as we present this COVID is here to stay, an idea that this human-to-human virus now will not only continue to mutate, but may come back again, I want to assure the community that the scientists are learning so fast about how to attack and to mitigate that. And I believe that the inflection point of getting to a vaccine, possibly before the next season, if there is a next season of this pandemic, that we will be on the cusp of a vaccine or close to a vaccine before that happens. So while we should be fearful about this virus, we shouldn't panic. I understand that there are great fears, both mentally, socially, economically, financially, about what will happen. We will deal with that in some of these other episodes. But from now, I want to assure the community that both the science, the medical community are hard at work to find solutions. Let me discuss the therapeutic strategies in motion as we begin to understand this disease, the three stages we've been discussing, whether it be yellow, the asymptomatic patient, orange, the patient that is really infected with varying degrees of symptoms, and then finally the critically ill or severe. So these therapies or these strategies, I believe, have to be tailored temporally based on where you are, where the patient is with regard to his state of infection. Obviously, an asymptomatic patient has the ability, first, not even to know he's infected, even though they may test positive for COVID, but the ability to basically self-isolate, not go to the hospital, not burden the healthcare system. But then we have the patient in the intermediate phase, what I call the orange, and then obviously the patients in the red phase. The reason for this temporal nature or temporal understanding of which strategy to use when is because the patient goes through various stages of the immune response. It is my belief that patients who have a compromised immune system are much more susceptible to this disease because they have absence of what we call the innate protective system of the natural killer cell that floats around our body, protecting us not only from cancer, but from any infective disease. So it is in these patients, whether the patient be elderly with diabetes, with cancer, or some form of immunosuppression, that the virus takes advantage of. And in the early stages, I believe, these patients could be benefited from having some form of activation of the NK cells. On the other hand, once the virus has spread within the body and replicated to such an extent that the patient cannot breathe or have difficulty breathing or has secondary pneumonia, the patient's body now takes over, the immune system takes over and fights so hard that there's what we call a cytokine storm. And clearly in those instances, in order to reduce the cytokine storm, to allow the patient to breathe, get off the ventilator, we need a different strategy. Not a strategy of, I believe, of immune activation, but in fact quite the opposite, a strategy of immune deactivation, the tamping down or cooling down of that period so that the patient then could fight. So I think the complexity of what I call this temporal nature is something we as clinicians are now beginning to learn, but we need to tie that to the treatments or the treatment strategies or the drug development strategies or the molecular strategies with regard to the disease itself. So let me turn now to the strategies with regard to the patients. The question is, and that's now pertinent to discussions in the news, are there drugs that are approved for other indications that we could repurpose? Well, for patients that are in these moderate or what they call orange phase, indeed there are drugs that firstly was needed to be in clinical trials and now has been recently approved under the emergent setting, this chloroquine and hydroxychloroquine. And how do these drugs work? Well, chloroquine and hydroxychloroquine actually works by preventing the fusion of the virus and preventing the packaging of the virus in these things called endosomes by affecting the pH of that virus. And this is really why in patients that potentially are in the yellow or in the orange have the ability to maybe take part into the clinical trial or be part of the treatment of hydroxychloroquine in this early phase of blocking the fusion and packaging of the virus. The next opportunity is, could one block the entry of the virus itself into the cell? And again, these are opportunities for patients in the yellow and the orange to participate, in which this ACE receptor, in which the virus activates and takes on this ACE receptor and finds a way to enter the cell, is an opportunity now for drug developers, molecular biologists, to understand the dance of this receptor as it interacts with the spike protein. This is really exciting because we now have at our hands these supercomputing GPU systems that could model what we call dynamic modeling every nook and cranny of the sequence of these proteins, amino acids, and find the ability to block the entry of this spike protein into this ACE receptor, and in so doing create a sponge or a trap and prevent infection in the first place, or for patients who already are infected with symptoms from getting any more virus from entering the body. And these will serve as what we call antibodies or traps. The next opportunity in patients who have, again, symptoms is to look at this machinery. And as we discussed in the last episode, the virus, once it enters, can only survive and replicate when it hijacks, as it hijacks the machinery of our own human body. So it takes over the machinery, it comes in, it breaks up into its different parts, and now takes over the machinery to replicate, and through what we call the Golgi apparatus and the ER, and reassembles. And in this replication of taking our machinery, it repackages and now spreads to the rest of the body. So there are what we call these antiviral drugs, the proteasome inhibitors or the adenosine analogs, such as remdesivir, where these can block and trick the virus so that it actually misreads or creates an incorrect reading and does not assemble. Unfortunately, I believe once the patient hits the phase in which the virus has replicated to such an extent that the patient is in the red phase, that it'll be very hard to overcome that until you get the patient out of that red phase. And then the other opportunity is to find a way in which patients can now activate their own immune system. So again, this is where it becomes tricky, because this natural killer cell, I believe, needs to be activated in the very early phase and maybe at the last resort at the later phase, in which the natural killer cell, which is in your body, is there to protect you from infection and can then be given early on so that it could kill infected cells through this natural killer cell activity and destroy the infected cell and prevent you from getting into the red phase. So I think the off-the-shelf natural killer cell, or an activation of this natural killer cell by a protein called a superagonist, are opportunities again in these early phases to prevent you getting into the red phase. Unfortunately, patients go into this red phase, and when they go into this red phase, this is where disaster hits. This is where the virus, I believe, is replicated to such an extent in these patients who are elderly, in these patients with pre-existing conditions, and unfortunately these patients who are deficient in the first place of their natural killer cells. What happens to these patients is, in fact, they have what we call full-blown SARS, which is really an inflammation and a cytokine storm in the lungs. What do I mean by cytokine storm? We'll be going into that much more detail in the following chapters. But cytokine storm is when the patient's own immune system is fighting so hard to try and protect itself, it causes tissue injury and ultimately death. So what is happening as these patients have what I believe these huge numbers of viruses, the huge viral load. And the viral load occurs in these patients with pre-existing conditions. It occurs in the elderly. It occurs in patients with diabetes, with cancer. And I believe that happens because these patients, in the first place, had a poor immune system or lower NK cell activity. But ironically, because they have a lower NK cell activity, with the onslaught of this huge viral load, it takes over this lung. What you see on this left is what I call a normal alveolus, or the air sacs inside your lung. These air sacs have a very special macrophage within them called, what I believe, an M2 macrophage. And that macrophage is not designed to kill and remove debris. And as you have this massive infection, you have this debris formation occurring. And with the debris formation occurring, you have fibrosis. And with fibrosis, you have scarring that prevents oxygen from entering from the air into the blood. You have then the immune system trying to fix this problem, and this is what you mean by cytokine storm. So interestingly enough, now is not the time, I believe, to activate the immune system. Now is the time to dampen the immune system. So this phenomenon of SARS is very similar to another disease we know in medicine called ARDS, in which the patients, again, have acute lung damage based on sepsis. It's very similar, I believe, to other inflammatory diseases such as graft versus host, in which patients, after transplantation, the patient's own immune system starts damaging the body. And we can learn from this that there are mechanisms and methods to tampen down this storm and have antibodies, IL-6 monoclonal antibodies, for example, to block this inflammation, block this fibrosis. There are mechanisms to activate or change the polarity of these macrophages so that they can actually remove the debris. There are mechanisms to increase the TGF-beta so that we can actually slow down and tamp down the inflammation. In China, they attempted the transplant or injection of a stem cell called a mesenchymal stem cell, which has been used for ARDS, which has been used for patients with graft versus host disease. And I believe under these circumstances, there are methods to quiet down the inflammatory storm and to overcome this terrible event and have the patient come off the ventilator quickly and live to fight and activate at that point the patient's immune system or give best supportive care to get the patient out of the ICU. So we have now presented today the therapeutic strategies in motion. While I've shared with you we have this pandemic and this virus here to stay, I'm extremely confident, based on all these strategies and based on the amazing speed with which both the regulatory, the government, the private sector, and most importantly, the healthcare and the scientists have moved, to actually put in motion these strategies in real time, whether you have severe disease, moderate disease, or critically ill disease, that we will have the insight and the understanding to overcome this disease. I'm confident, however, that in order for us to change this inflection, not for just now, but for the future, is a vaccine is needed. I'm confident, based on what I now see, that the vaccine is close at hand. So these therapeutic strategies are real knowledge that we gained from the SARS 2003, and with the power of the supercomputing in our hands and with the collaborative effort of the world, I think we will have a chance to deal with this virus. Let's turn our attention to the asymptomatic patient, the patient that is infected, is COVID positive, but is asymptomatic. I want to remind everybody what I feel there are 3 stages of this disease. We've termed yellow, orange, and red. In yellow, you have what I call stage 1, where patients, in fact, are positive, infected, but without symptoms, don't even know sometimes that they're infected. And their job is to limit spread, and we'll get into that. That's their only job, is to limit the spread. On the other hand, patients have flu-like symptoms. They have muscle aches, some myalgia, a minimal cough, not greatly short of breath, and are what we call mild. And our job is to find ways to reduce their viral load so that they don't go from orange to red. And then finally, there are these patients who are in full-blown SARS, the elderly, the pre-existing conditions. And I think we have yet now a real challenge is to overcome the lung damage, reduce the fatality rate in these patients. So if we categorize or create these buckets, it gives us, as both scientists and medical scientists and clinicians, an opportunity to understand what I call the temporospatial nature of this disease and where in the spectrum of this disease we need to treat and what treatments to use. Obviously, at the end of the day, we want to find a vaccine to really prevent anybody from getting this infection. And it turns out that I believe 40 to 60% of the patients who are infected are asymptomatic, and 80% of patients are in this bucket of flu-like symptoms or asymptomatic. But the terror for our loved ones, for the elderly, is that these patients in the stage 3 disease have such a high mortality rate that we need to find a way to even prevent this. What is most disconcerting is that while this started stage 3, the red, in the elderly, it's now moved in our country to some of the young. And then sadly, even the youngest child has now suffered a death as a result of full-blown SARS. So on that basis, I will now like to now start on trying to break up these categories and speak to each of these categories of the stages of COVID. And let's start now with the asymptomatic patient. I believe this is why we have this immense spread, because these are what I call the super spreaders. The patient being infected has no idea that they're infected, so they may have minor or have no idea. But I think this is the value of the stay-at-home policy. Until we can do all the tests, until we know who's infected or not infected, the only policy to provide containment and flatten this curve and not overwhelm the system is this self-isolation or stay-at-home policy. These patients, because they're infected, should truly be with face masks. So the purpose of testing now is to identify these patients who should self-isolate, who should use separate rooms and bathrooms, and as we've talked about in the past, wash their hands constantly. And this is also different with regard to this virus. It appears now from studies that the viral load in the respiratory system of patients who are asymptomatic can be as high as if they had symptoms. This video was taken at 2,000 frames a second from a healthy person during a violent sneeze. And as you could see, as the sneeze progresses, it goes 20 inches and then goes on to progress to 43 inches. And the remarkable nature of this is if it's taken then by a plume, what they call the physics of a gas plume, it could go as far as 20 feet. While this is unlikely that most sneezes go that long or far, as much as 26 feet, I think the point of this video is to say that within 26 feet of this infected person, surfaces can be contaminated. Pavements, door handles, paper. This is why we need to understand that these patients who are asymptomatic in environments like this have the capability of spreading and in generating this pandemic. This video, taken again by another company, I can vouch for the veracity of where the data comes from, other than, according to the reports of this company, it comes from mobile telephone data. But I think the point again here is at Fort Lauderdale, this is one single beach at spring break. A single beach at spring break in which potentially these young people are asymptomatic, traveled, and now you see their phone records in a very short space of time across the seaboard and the eastern seaboard of the United States, and even up to the Midwest. On the other hand, if you took the approach as we've done now in California, and again credit to the governor and the mayor of our towns, we've closed beaches, we've actually closed parks, we've banned gatherings, we've asked families to stay at home. For the first time, there are very little traffic, and credit to the community. They've actually accepted this because we are all in this together. This is the importance of us flattening the curve and causing an extinction of this virus. We have in our control the ability to cause an extinction of this virus by not giving it a host to survive. These young people at least are wearing masks. The idea that if you're infected and you wear a mask is not just to protect yourself, thinking you're not infected because you're asymptomatic, but to protect others from the droplets that can come from your sneezing or coughing. But I don't think it's very clear to most in the public that there's a very much difference in the mask you wear. If one were to look at this person's mask, you would see a great difference between this person's mask, and the difference is this exhalation valve. What this means is that in this exhalation valve that is present in this person's mask, both N95s, is that the droplets can emerge from the exhalation valve. So the opportunity, unfortunately, completely defeats the purpose of this person protecting the rest of the community. So I would urge those who are infected and understand that they're infected, that this is the mask they should be wearing and not an exhalation valve, as has been attested by the CDC, who have shown that through these exhalation valves, in order to maintain a sterile field, the exhalation valve itself does not protect that. And why is this all so important? Why am I emphasizing the importance of the responsibility of those that are asymptomatic and infected to stay at home, protect others through appropriate wearing of the appropriate mask, the fitted mask for medium, small, and large, is because of the healthcare workers. These are the professionals that are necessary and needed to treat even the moderately infected, but more importantly, those severely infected with a fatality rate of 50%. As can be seen from this Instagram and Twitter posts, here you have these professionals who are on the front line, and they put their lives at risk to save all of us. And this statement says, we stayed at work for you, you stayed home for us. So I cannot emphasize more the importance of the young people understanding how difficult it must be, that they are asymptomatic, feeling good, that it is their responsibility to stay at home, stay isolated. And unfortunately, the period of time, while the median goes 14 days, there's evidence of 20 days, and even evidence of 30 days in which the virus stays within your body. So the longer you self-isolate, the better, so that we can protect the healthcare workers and protect the community and protect your loved ones. Let's turn our attention to the symptomatic patient. And unfortunately, this particular virus appears to have a high incidence or prevalence of patients who are asymptomatic yet infected. And until we can test everybody, which unfortunately is not possible today, the only way for us then to contain this virus is to make the assumption that the young people, even though asymptomatic, are positive. And only by doing so could those who are asymptomatic and positive and don't know it prevent the spread. So I wanted to make sure that everybody understood the word asymptomatic did not mean non-infected. Quite the contrary. We need to emphasize that a large proportion of patients are infected but have no symptoms and therefore can be the spreaders. But let us turn our attention to the symptomatic patient. And by that, I mean the patient that has the feeling of flu-like symptoms and who has a real important need to reduce their viral load. And the reason for that is we need these patients to recover and not progress to red. So these are the patients we call orange. And very much like the asymptomatic patient, need to self-isolate inside their homes, but require supportive care. They should, and I emphasize this, avoid home remedies, which we'll talk to a little bit as we proceed through these symptomatic patients who are managed at home because of the danger of so-called home remedies. It is important for these patients to know when they should reach out to their physician, and in fact, when they should be hospitalized even, because the onset of pneumonia from orange to red could be very rapid, and from red to on a ventilator could be extremely rapid. The other issue that I want to discuss with regard to the symptomatic patient is what drugs are on the market today that are repurposed for this disease. And then finally, the opportunity, as I said, for us to avoid the fatalities of these patients or reduce the fatalities of the patient who go into the red phase and who have this severe lung damage and who are hospitalized. It is clearly the goal to take a patient from red back to orange and to prevent a patient from orange becoming red. So let's start a little bit on these patients who are symptomatic and the questions that they need to understand. First of all, let me just revisit again the difference between orange and red and how a symptomatic patient gets infected through the nose, through the mouth, through the eyes, through the mucous membranes into the lungs. And once into the lungs, these viruses attach to the ACE receptor. And once in the ACE receptor, it starts infecting the alveolar cell. You will see this alveolar macrophage, and we will, over the next few series, talk a little bit more detail about what is this alveolar macrophage, which I label as M2, and what's it doing there. This is your normal macrophages that cleans up what's inside your lung. And these mild to moderate patients have some level of infection in the lung, but not overwhelmed. This ACE receptor is here to protect the lung with mucus, and the surfactant layer is a protective layer of the lung so that the oxygen can be passed from the lung to the blood vessels and to the rest of the body. This is the alveolus. This is what we call the alveolar sac, and this is what happens in the infected patient. So we begin to understand the basis of this infection and how it occurs in the lung. So what are the symptoms? Well, I say follow the ACE receptor. And this receptor sits at the base of the tongue, in the nose, and because it sits at the back of the tongue and the nose, there are now reports of loss of taste and smell. So that could be a symptom of an infection, a positive COVID infection. The receptors are in the alveoli of the lung, and that's why a dry cough, which actually goes all the way on to difficulty in breathing, with the respiratory rate which is higher, which we'll get into. The ACE receptors are in the GI tract, so diarrhea and stomach cramps could be a symptom. And then they are in the blood vessels, and patients with hypertension are higher risk of this because there's higher exposure of ACE receptors. And then finally, these ACE receptors are in the what are called the immune cells themselves, and there's even a backdoor to the immune cells where the virus has figured out a way how to actually evade the immune cells or kill the immune cells. But the body fights back as you get this infection and the secondary infection, and you have a temperature. So if you look at the what happens in patients with these symptomatic infections, you could have loss of taste and smell, you could have a dry cough, diarrhea, hypertension, and high temperature. These are clear symptoms that you may have an infection and need testing. So what happens when you need these testing and you know you are positive? How do you know that you have to go into the hospital? What requires hospitalization? Well, as I said, this is a very dangerous disease, and you really need to understand how rapidly this can progress if you're not careful. So a positive COVID test could be asymptomatic, or you could be just mild to moderate. Presence of a high fever clearly begins a demonstration that is pneumonia occurring, is a secondary infection occurring, which then requires hospitalization for you to go and see your physician. A high respiratory rate, and what we mean by that, as your lungs have much more difficulty in terms of inflammation and fibrosis and fluid, the passage of oxygen requires much more of a rate. The normal rate, 8 to 12, goes to 20. So the counting of your respiratory rate, the need to take much more breaths more rapidly in order for you to feel comfortable, is not a good sign saying that you need to be in hospitalization. The oxygen saturation, where you can measure the oxygen saturation from your blood levels, these are all a consequence of now the lung becoming affected, and a chest X-ray that shows pneumonia. And then finally, 100% of patients with a positive COVID-19 infection have this appearance on CT scans of a ground glass effect and fibrosis that occurs. While this is a test that absolutely confirms the positiveness of severe COVID, it's not recommended for everybody because the radiation effect of a CT scan in its own right is not safe. So the medical signs that require a patient that is symptomatic in this orange state to be very aware that could go very rapidly to the red state, that with a high respiratory rate, a low oxygen saturation, evidence of an infection, difficulty in breathing, these patients need to very quickly get to the hospital. So in this instance of a patient in this orange state, what have we learned from SARS in 2003? And that's been at least the blessing of some level of experience that SARS 2003 and SARS-CoV-2 have the commonality of the fact that it's an ACE receptor and that the virus in its replication stage has some of the same characteristics. And we talked about how chloroquine and hydroxychloroquine and now azithromycin have been talked about with regard to opportunities to reduce the replication. Remdesivir, Kaletra, these are two antiviral drugs which we'll talk about. And there's a whole slew of other drugs, methotrexate, amiodarone, and the question, which is much more complex, about whether one should be on an ACE inhibitor or an ARB inhibitor for hypertension. These are questions that, frankly, we do not really have full answers. These are questions that require clinical trials. These are questions that require clinical understanding at the clinical practice level. But in times of desperation, it is clear doctors, hospitals, and even patients themselves are taking on these drugs that are on the market for their own use. So let's talk about some of them. Chloroquine, hydroxychloroquine, Plaquenil, they're basically the same chemical structure. And this is chloroquine, which is discovered for malaria. So it's an old anti-malarial drug. And then the hydroxychloroquine, which is a derivative of the chloroquine, was developed so that you could have a better solubility. And it appears to have a higher efficacy. I say the word appears because we're not sure even of the true efficacy of this until we do the clinical trial. So there's chloroquine, hydroxychloroquine, and the trademark name of hydroxychloroquine is called Plaquenil. There's been a very small study that says if you combine chloroquine, hydroxychloroquine with this antibiotic, there seems to be even a synergistic effect. There may be some evidence that this is an anti-inflammatory mechanism, but it's really unclear how and why this combination works, if it does. But before we move on from this chloroquine story, I do want to emphasize that this drug, hydroxychloroquine or Plaquenil, is actually approved for patients with lupus and patients with rheumatoid arthritis. So it is very important for us to understand in the community that these drugs are in great need for patients who really do need them on a day-to-day basis. So luckily or happily, I think the pharmaceutical companies are now increasing the manufacture of these two drugs so that we do not run out of supply for those who really need it in its approved state. What is the theories of how hydroxychloroquine works? Well, one, it actually affects this ACE receptor through a thing called glycosylation. Two, it affects the fusion of the virus into the membrane because of the pH. It changes the pH. And three, it actually affects the endosomal packaging as well as this thing called RNA polymerase. So these are the theoretical reasons of why these findings prompted the early testing of chloroquine for COVID-19. And with regard to the effectiveness, well, from China there were conflicting results. On the one hand, there were some results that said it's effective. On the other hand, when they did a randomized study, they showed no difference. So this is why it's important for us to understand that it is correct for the FDA to say we need randomized clinical trials with this against placebo. There's been a report, widely touted report from France, that only in 6 patients, when you do combination of chloroquine and azithromycin by day 3, the viral load was significantly decreased compared to controls. This looks promising, it's the best way I could say, but again, until you do the clinical trials, we won't know. Having said that, one has to be super careful because one of the problems with hydroxychloroquine in its side effects is arrhythmia, which is a rhythm of the heart, which could in itself could be fatal. When combined with azithromycin, that arrhythmia complication increases because both could have such an effect. Before I go beyond just the chloroquine, This is the danger of, I believe, television, of an uninformed audience. What was remarkable when the chloroquine phosphate idea came out, there was a run on chloroquine phosphate that was used to clean fish tanks. And people would be taking this chloroquine phosphate in water and drinking it as if this would be a prevention for COVID-19. And sadly, a person died. So a great warning, no home remedies, and chloroquine phosphate is not fit for human consumption. Another warning, as I just shared with you, that the combination of hydroxychloroquine and azithromycin raises the risk of heart irregularities. So it's not without risk, even though there may be a desperate need to try and self-remedy. If you are going to go on these two drugs, you should do it with the coverage of a physician inside a clinical trial. Having said all of that, amidst these controversies, FDA has now issued an emergency authorization allowing this hydroxychloroquine to be used in the treatment of COVID-19. So I leave you with the hydroxychloroquine that it is proved under these emergency conditions, but is still not without risks and has to be fully proven. Which then takes us to the next set of drugs called remdesivir, which some of you may have heard. What remdesivir is an antiviral drug that was developed by Gilead for Ebola. And it is what we call a nucleotide analog. In layman's terms, it's here to decrease the viral replication by tricking the virus into creating a version inside the machinery which inhibits the replication. So this complex science here called RNA-dependent RNA polymerases inside the machinery, and that's what remdesivir potentially does. And also this proofreading capability of this amazing virus, it actually may inhibit that. There is good science about why this would work. Having said that, again, it's unproven until the clinical trials are completed, and there's a large remdesivir clinical trial going on. The Solidarity trial is a trial where all the known antivirals, such as remdesivir, such as Kaletra, which is an anti-HIV drug, as well as the antimalarials, are all being tested. And that brings us now to Kaletra and interferon beta. So Kaletra is a combination of two molecules or two chemical agents, one called lopinavir and one called ritonavir. And these molecules are really anti-retrovirals. It's a little complicated because HIV is a different kind of virus, what we call a retrovirus, and they're used in HIV. The thought process being here that these drugs, while effective against HIV, may be effective against COVID virus by inhibiting these things inside the cell, again through the machinery called these proteases. We don't know this yet. These drugs, however, are toxic, have severe side effects, including things like pancreatitis. Again, should only be considered inside the world of clinical trials. While I've summarized in a very limited fashion some of the well-known drugs that could be repurposed, there are many being considered. Some like Amiodarone, which is used for arrhythmias, they may also have a role in preventing fusion. And then there's this whole discussion about ACE inhibitors versus ARB inhibitors. What do I mean by that? Patients now on antihypertensives, there's a drug that inhibits ACE. ACE is separate from ACE2. ACE2 is protective of the lungs. ACE is injurious to the lungs. ACE2, however, is where the spike protein binds. So should you be having an ACE inhibitor or an ARB inhibitor with regard to these two receptors? Should you be on these drugs at all? Should you change one for the other? The answer to this is all unknown at this point. These are interesting scientific questions, and the recommendations now from the American Heart Cardiology Associations are, in fact, you should not make any changes at this point. So These are complex discussions about repurposing old drugs, which says that there are treatments for drugs that could affect the machinery, the fusion, or the endosomal packaging, all for the purpose of reducing the viral load inside the infected cell by the virus, so that these patients don't go from orange to red. As I said before, the inflection point for us is to get to the vaccine. On the other hand, there are treatments on the horizon, which we'll speak to, that can even treat these symptomatic patients before they have the cytokine storm, so that we can actually kill the factory. And that is potentially the use of NK cells or the use of IL-15. But that again should be a subject of clinical trials in the future. So with that, we will then move on next to the critical patient. I'm now going to turn my attention to what I call red, or the critical patient. These are the patients for which we are really worried about as healthcare professionals, as surgeons, as scientists, as anesthesiologists, as nurses, because these are the patients who end up tragically not only on ventilators, not being able to be seen by their loved ones, but a 50% fatality rate. It is really important for us to not only understand the pathogenesis of why these patients die, but how can we stop it? How can we actually get them out of this terrible situation called SARS, which is severe acute respiratory syndrome. For full disclosure, I, as a physician and scientist in our organization, ImmunityBio, made a concerted effort, at least for this particular point in time, to focus huge amounts of our effort to see if there's any way we can mitigate this terrible event of high fatality rate of close to 50%. So let's discuss these critically ill patients as they enter the intensive care unit. These are patients who have severe lung damage and require ventilation just to keep alive. I think one of the goals for us as physicians is to find a way to rapidly discharge these patients from ICU. They are hospitalized in intensive care, and in these instances, I think next generation immunomodulators are needed. And I'll describe what I mean by immunomodulators. Let's first try to understand what's going on in these patients. And as you recall, I was explaining how this virus enters and it binds to the ACE receptor, and how it gets in and it fuses with the membrane and with the spike protein, and it breaks up and it takes over and reassembles and creates rapid replication. And then there's endosomal transport and out of the lung, and it sheds. All of that is what happens until you get this huge replication of this virus inside the cell, with inflammation and tissue damage and lung damage and fibrosis. And once you get to this stage, you end up in the statement of SARS. In a normal circumstance, your lungs have this pockets called alveoli. That's how these pockets of alveoli actually take in air, and the oxygen is transported very carefully back and forth into the blood, and that's how your body's organs are oxygenated. When the virus enters and hits these alveolar cells through the ACE receptor, it turns out in this area, the type 2 cells, are macrophages called M2 macrophages, which are not quite designed to clean up debris. They're there as sentries, but more as suppressors than activators of the immune system. So when the cell is overtaken by this virus, the body then reacts, that allows this virus to create fibrosis and damage. But it's not just the virus that's causing the damage. Unfortunately, it's your own body creating the damage, in the sense that it's now releasing these, what we call cytokines, and creating fibrosis. And when it creates a scarring, all of a sudden it's impossible for the oxygen to easily travel to the blood. And this is why the patients require ventilation to open up these airways. In this instance, what is needed is to tamp down this inflammation, to tamp down the ability of this self-tissue destruction from occurring. And there are other diseases that look like this. Some of them they called ARDS, which happens when patients have sepsis. It's also called graft versus host, where patients have their own transplant takes over and the body itself causes the same kind of damage. What has been used in those calamities have been ways of actually transplanting cells that would enter here, that would tamp down this storm, and these cells are called mesenchymal stem cells. So this opportunity to take this horrific episode that's overwhelming the system and take these patients who are in ICU and ventilation and bring them out of this 50% survival rate and increase that survival rate to reduce the time they spend on ventilators. It's reported they spend 14 days on ventilators. That's one of the reasons of why they're overwhelming the system. In order to reduce that, the opportunity is to look at selected trials in motion. So some of the trials in motion is this drug called an anti-IL-6 or IL-6 antibody that tries to block the storm, and it's now in clinical trials and used for patients with severe disease. Whether this is effective, fully effective, yet again is not known. There, as you know now, talks about using convalescent plasma. We will get into that in more detail as we get to talking about the race to the vaccine. But convalescent plasma means that these patients who had the disease have in their blood antibodies that could basically ameliorate the infection and stop this inflammatory storm. What I'm most excited about, however, is to find ways to, one, kill the factory itself, but it'd be difficult to enter into this environment from which there's huge storms to add yet another potential storm with a natural killer cell. I think probably this natural killer cell needed to have been there before the storm occurred in the moderate phases. Ironically, what is needed right now is not to increase the cytokines, but to dampen it down. And one of the opportunities is this concept of mesenchymal stem cells, in which mesenchymal stem cells could be grown from a patient's bone marrow. Any donor bone marrow or adipose tissue could be taken, and these stem cells actually exerts a system secretion of a protein called TGF-beta. And that TGF-beta would actually reduce this storm and has been used in patients with graft versus host disease and ARDS. 7 patients have been treated with this in China with severe COVID SARS. What was exciting, at least, is that these patients all significantly improved, and in 2 days after this transplant of a single injection of these mesenchymal stem cells, were able to leave the ICU. It remains to be seen whether this is a real effect, but if it is a real effect, here is truly a way to mitigate the death of these patients, for which we have a 50% death rate. And we are working diligently and have created, again, with full disclosure in my own company, over 10 years, built this machine with artificial intelligence that actually could take bone marrow from a donor and through this machine grow stem cells automatically. And within 7 days, generate a dose that could be used to treat patients. We are applying for clinical trial approval, and it remains to be seen the effect of this as a stopgap measure. I say that as a stopgap measure because our goal is not to wait till patients to get to this stage. Our goal is to prevent the patients get to this stage, and our ultimate goal is the race for the vaccine so that everybody is protected from this disease before infection occurs. This is where it becomes really important, the race for a vaccine. Because without a vaccine, we'll be forever fearful of a pandemic like this again. So I will spend some time on this section, but it really warrants a full episode in which we'll talk about the progress made as we monitor the progress made on this vaccine. So what are we trying to vaccinate against? As I said, the coronavirus is an RNA virus, but this is a nuclear capsid inside, and this is actually what we call the structural protein of the virus. And then these are the membranes on the outside, and this is the spike protein. So between these two proteins, there are conserved areas. What we mean by that is that whether it converts from SARS-CoV and SARS apparent to the daughter SARS-CoV, and these spikes are mutating as we speak, there are certain proteins in the virus that are necessary for the survivors to replicate itself, what we call structural proteins. So the ideal vaccine would be to create a vaccine against a structural protein and a vaccine against spikes or some of these other proteins that are on the surface. And that is the race today. We've never seen this virus, but we have, thanks to the Chinese presenting very early on, the genetic signature, the genetic code of the capsid and of the spike. Having said that, this is a huge virus. When I said huge, it means about 30 kilobases, which is pretty large for a protein. So we have to find a way to create a vaccine that could teach our own cells about this protein and recognize it as foreign. This is akin to cancer, because when you have cancer, you have a mutation in your normal cell, and that mutation in the normal cell, very much like a virus, is an abnormal mutation that resides in your cell that can induce the cancer. We call that the neoantigen, and we need to engage our T cell as a neoepitope. There is no difference between that challenge versus this challenge of trying to find a vaccine against the equivalent of a neoepitope by finding a way to teach our T cells to recognize either this or recognize the nuclear protein and kill the virus itself or kill the cells which are infected with the virus. There's this concept of neutralizing antibodies, and what do we mean by that? Blood from people who recover from the coronavirus actually develop these antibodies. So it is possible then to take the blood from a patient that has survived, or the plasma that has these antibodies, and infuse it into a patient that's infected and allow these antibodies to neutralize, so to speak, the virus. These antibodies then are seen by our macrophages, called M1s in these cases, that phagocytose and kill the virus by actually eating them and breaking them down and destroying the virus itself, or taking the cell that is infected with the virus, and these antibodies would attach to them, and then we have our natural killer cells that bind to these antibodies and kill the infected cell. This is killing the factory. So this is what we call B-cell mediated immunity or humoral immunity. So the opportunity then to take as a short blood from people who have recovered as neutralizing antibodies and use these neutralizing antibodies to either kill the virus itself, induce our macrophages to eat the virus, so to speak, and induce our natural killer cells to link to these antibodies and kill the infected factory itself. If we then say, okay, we'd like really longer-term immunity, and that is called cell-mediated immunity, meaning you want to get to a point where your T cells have memory, so that the next time you have this infection, your body is ready for it. And you do not get a severe case of the infection, very much like how we're treating influenza today. We have now used and are using a modernized version of this common cold virus called an adenovirus. And so, ironically, we're using a virus to kill a virus. And this adenovirus could be then taken and engineered, not with its own code, but with the code of that of the coronavirus. So the first step is to find that code, that sequence, which the Chinese have done and shared with the world. And now taking those sequences of either the N or the spike or the membranes and putting these sequences into the adenovirus. So you now have a vehicle or vector with this particular injection of this vehicle to infect your own dendritic cells. So this is the educator cell. This is the cell that needs to be trained so that you could take a T cell that is naive and start educating the T cell about this virus. Once you have this educated T cell, you have what we call activation and clonal expansion resulting in the memory T cell, and now you are vaccinated. So this is what we mean by cell-mediated immunity. The irony is that this virus vaccination is no different to what we are trying to accomplish with regard to cancer, because we could use this exact same vehicle, put in the cancer sequence, which is unique only to that cancer, inject it into that patient, educate the dendritic cells, and now have educated T cells to go after the cancer cells. So this is a universal mechanism of your body protecting yourself not only against infection, but protecting yourself also against cancer. So to summarize, let me speak to the two mechanisms of how the vaccine works against COVID. On the one hand, you have B-cell immunity, and you have these neutralizing antibodies that either could be obtained from a patient's blood that's recovered, or what's exciting is actually being generated. If one could sequence the spike and go into a library and find these neutralizing antibodies, one could generate these neutralizing antibodies. And now these neutralizing antibodies would be able to be combined with natural killer cells. These could either be natural killer cells that your body is making naturally, and that could be stimulated with proteins that you could inject called IL-15, or you could give natural killer cells that you could grow off the shelf. So this is one way of inducing killing as well as a vaccine through what we call B-cell immunity. This killing of the natural killer cells tied to the neutralizing antibody has a special term called ADCC. And then finally, within the neutralizing antibody, there is the opportunity to have this macrophage going from an M2 to an M1 to also kill. So if you look at this board, you begin to see the beginning of what I call the killing fields of the triangle offense, because you've got one and you've got two, and now coming to the third, which is the T cells. So between the natural killer cell, the macrophage, these are two of the killing cells. But what's very exciting is the opportunity to induce longer-term immunity, things we call T-cell-mediated immunity. And as I said, your body has never seen this COVID virus. So you have what we call an immature dendritic cell. A dendritic cell is ignorant about this virus. So how do you educate it? Well, if you had a virus that is not the COVID virus, but a virus that is safe to give and that has been depleted of its ability to replicate, and such a virus exists called the adenovirus, and you place inside the adenovirus the COVID sequence, now you have the ability to take this adenovirus, inject it subcutaneously, and allow that adenovirus to educate these dendritic cells. Now you have a dendritic cell that is educated about COVID. And now we have the first time then an opportunity to take a dendritic cell and activate a T cell and cause this T cell to become a killer T cell, so that this killer T cell then can go after a cell that's infected and induce what we call immunogenic cell death, kill the factory, and at the same time generate memory. So these are the two mechanisms of killing. I call that the triangle offense. On the one hand, you have a natural killer cell, then you have the M1 macrophage, you have the dendritic cell and the killer T cell, all to get you to the memory cell. So this complex science, this complex board, should give all of us hope that this virus is not going to beat us. We have well-established methods now to be able to rapidly get to a vaccine and manufacture it. In the past, manufacturing of vaccines, as you could see and still is, very cumbersome. The herpes vaccine, the pox vaccine, the influenza mumps vaccine, etc. were manufactured through eggs and still are. So that's a huge challenge in terms of scaling the manufacturing of these vaccines until now, where we've now modernized using the adenovirus as the vector, putting the gene sequence into the adenovirus, growing these adenoviruses in large vats and injecting doses. So the opportunity now to get millions of doses and even billions of doses are very real. And I was excited to see that Johnson & Johnson and BARDA entered into a billion-dollar vaccine research trial to achieve exactly that. In full disclosure, we have exactly a adenovirus vaccine we have tested in cancer patients, and we are completely committed as well to be looking at our platform. In the meantime, this video put out by Janssen and Johnson & Johnson very nicely demonstrates not only how this adenovirus platform is scalable, has demonstrated safety, and can bring the vaccine to us earlier than expected. This vaccine video demonstrates very clearly how this antigen is built onto this adenovirus and how it can be used. What is really important as a inflection point is the race for a vaccine. Only then could we change the path of this pandemic and be ready for the next 100 years. But then we will really be in so advanced and be prepared for anything that comes along. And no way will the virus be able to take over mankind. I don't think our scientists of the world will ever tolerate that. In summary, we've spent time in this series first saying that the COVID is here to stay, but presenting at least therapeutic strategies that says help is at hand. We understand this. We can get there. We're going to be able to treat the patient with mild disease. We can treat the patient with severe disease. We can try and reduce the fatalities that happen today. But most importantly, we have a race for the vaccine, which we believe is close at hand. Again, with full disclosure, our scientists at our organizations at ImmunityBio, NantKwest, and NantWorks are working 24/7 to take on this race. We will be back in the coming weeks with another installment of this series, in which we will look closely at the race for the vaccine. For now, we'll say goodbye with these images of healthcare workers here in California and across this country, working at great risk to themselves on the front lines of the fight against COVID-19. Indeed, these are the warriors and the heroes of our time.